Good afternoon, everyone, and welcome to this afternoon's edition of Black Health Trust. We are so happy that you have chosen to join us, and we promise you an exciting conversation this afternoon because we are going to be addressing two topics of utmost interest at this time. One is around the question of mental health in the age of COVID, and the other is a discussion about the new variant that is getting all the headlines. Our mental health discussion will be led by Dr. William Lawson, and my mutation discussion will be led by our one and only, our own virologist. Do I even have to say his name?
Yes, you do, Dr. Dispani.
He has such a following, I hesitate to even assume that I have to speak his name. Without further ado, I'll turn the program over to our founder and leader, Dr. Randall Maxey.
Good afternoon, everyone, and welcome to the Black Health Trust. We've been doing this almost 2 years now, trying to bring vetted, valid, life-saving information to communities of color. I'd like to thank our co-moderators, Dr. Barbara Neighbor-Stevens, noted pediatrician, Dr. Ivan Walks, noted psychiatrist, and our newest, I won't say youngest, even though it's true, Dr. Jocelyn Hines, family and emergency room physician in the state of Maryland. So we'll go right to it. But before I do, and I tell people I'm a scientist, I'm a physician, but I know where real power and knowledge comes from. And I would like to start this program mentally and spiritually in prayer for all of us who have family challenges, societal challenges, personal challenges, that we jointly acknowledge and give praise to the Lord Almighty and the blessed mission of the Black Health Trust and all of those who work with us. So we'll start our program, and we have a disclaimer that this is not medical information that we're giving you on the call, but rather medical advice you can suggest and talk to your health provider with. But it's very clear that we think it's good information, but make sure, because everybody has an individual situation, you should talk to your physician or healthcare provider. And now, my leader and my psychiatrist, Dr. Ivan Walks, would you introduce our first speaker?
Yes, Dr. Maxey, I am happy to do so. We are in for a real treat this afternoon. Dr. William Lawson is not even arguably, he just is one of the top mental health leaders in America, in the world. I say that because he is not only a noted psychiatrist and has a tremendous clinical background, he's also been involved in leadership roles with respect to health policy and with respect to running training programs for mental health. So he's been chair of the department at Howard University. He's been chair of the department down in Texas. He's done so much over so many years and is one of the most respected individuals in the field of psychiatry. And mental health has been getting a whole lot of notice as of late with respect to impacts from COVID. So we wanted to have someone who could really talk to us about that in that practical teaching way that Dr. Lawson can do and help us understand how is this COVID world we're living in impacting mental health. Dr. Lawson, please take it away and help us understand.
Well, first I want to give my thanks to Dr. Wilbur Jordan, who showed me how infectious disease had anything to do with mental health in terms of HIV. And also I'm going to be work very close with Dr. Walks, who's also showed their relationship as well. So will I be operating these slides from here?
So Simon can work them.
Okay, let's go to the first one. Okay, mental health consequences. Next one. Do I need to push a button? I'd be glad to.
If you just say next, I think Simon can take us on through the slides.
Okay, as many of you know, coronavirus, big thing was this was detected in China back in 2019. At that time, it was novel, no built-in immunity, reliable vaccine, a confirmed treatment. Perhaps at some point we can talk about its origins, but not now. Next one. It's a new disease, ease the spread. And interestingly enough, a similar outbreak occurred in 1918 for reasons that are still being examined, why there was not the publicity and the information that occurred with the 1918 outburst as with this one. The 1918 outbreak, there was almost nothing in the history books, and yet it had tremendous mortality and psychological consequences. And I think part of the lesson that we have forgotten is that the 1918 outbreak was associated with a lot of psychological aspects. Next one. So it was the most severe pandemic in recent history. Estimated about 500 million people died. I think we're going to pass that. And at that time, these that did not have the technology that we have today, didn't have the vaccines. They only had isolation, quarantine, hygiene, use of disinfectants. Interestingly enough, many of the same kinds of issues in terms of personal liberty and personal rights existed at that time as well as today. And there were vast differences in terms of mortality rate in different states because the willingness of the people to participate in appropriate isolation and quarantine versus other places where people essentially ignored it. Next one. So the important thing is that what we find that there was a number of first-time hospitalized patients with mental disorders attributed to influenza increased by a factor of 7.2 in the 6 years. The survivors reported sleep disturbances, depression, mental distraction, dizziness, difficulties coping at work. During that years, the suicide rate also increased, and there was a pronounced increase in some neurological diseases. Next one. Next. And what we now know is that we have a high hospitalization rate, high mortality rate, and creating a lot of fear in vulnerable population. Most of all, the spread, unlike say HIV, the spread during routine activities is high and created fear and anxiety. Next one. Who's at risk for neuropsychiatric complications from COVID-19? Well, pretty much everybody with comorbid conditions. And these are also associated with death, diabetes, hypertension, vascular brain disease, coagulopathy. Many people with pre-existing psychiatric disorders have increased comorbidity with this disorder. Next one. These include polyneuropathy, myopathy, large artery ischemic stroke, anosmia, and ageusia. I just want to note that before I came into medicine, I was actually heavily involved in research with taste. So I became very interested in looking at olfaction and taste in terms of this disorder. We already know that there's a lot of morbidity in the taste issue, especially with chefs because of its impact in terms of their profession. Also, there's complications of hypothalamic and caudal neuroinvasion. We are doing research now that pretty much, I think, shows that the neuronal hypothalamic invasion is extremely important in terms of taste and smell. Next one. It's associated with altered mental status, agitation, affect, and behavior. Delirium associated agitation found in 80% of those in the ICU. Executive dysfunction was found in 36%. I think that's an underestimate because they didn't do the kinds of dysfunction tests that a lot of us do for other kinds of illness, such as schizophrenia. Delirium also well associated, and the brain fog syndrome, which we've talked about previously, and frank catatonia, which many of us thought was pretty much almost extinct in the US, but now began to reoccur again. Next one. So how is this happening? Probably actual viral infection of the nervous system, dysregulation of cytokine activation, some autoimmune mediated mechanism, hypoxemia, thrombophlebitic, homogeneous spread of the SARS virus. Next one. What do you do with these kinds of treatments? People have used melatonin, they use alpha-2 agonists, antipsychotics, atypical antidepressants. You might want to add that the good news is that the newer antipsychotics and the atypical antidepressants have far fewer side effects than the older agents, but still they have side effects. Next one. Also, mood stabilizers, dopamine agonists, and I might add that some of us who work with the long haul syndrome, I've been very impressed at how ineffectual many of the dopamine agonists and many of the stimulants are in terms of dealing with that syndrome. Benzodiazepines, which have their own issues, and also various antivirals. Next one. But again, the big thing, of course, is the psychosocial impact. That is routine activities spread, creating fear and anxiety. And the recognition that social distancing, social isolation, and personal isolation is necessary because of treatments where they can prevent hospitalization really don't impact greatly in terms of the spread of the disorder itself. So social distancing is important. And that has a lot of implications in terms of people of color. And again, vaccination, important. But it's conflicted with strong suspicion and some belief systems in the African-American community. Next one. Also, there are a lot of psychological factors. There's fear of death, direct effect, of course, on neuropsych sequelae, growing evidence of increased risk of depression in COVID-19 survivors. Don't really know if this is regarding the psychological consequences of the disease itself. We see a lot of people presenting with frank major depressive disorder who've been infected and who have recovered. So I think it's early to know what's the long-term impact that this is going to have on mental health issues. Next one. The psychological factors include the fear of exposures. African Americans often are frontline workers who often do not have the worker protection to say, no, we're not going to do this job in this dangerous situation. So there's an ongoing fear of exposure, and the reality folks had to make a choice between their jobs and their living. Then there's preoccupation with use of protective equipment. We found in some places that we can't get it. N95 masks, I was trying to get in a drug abuse center, just weren't there. We actually had to have a nurse go out and spirit some from a nearby hospital to help our clinic. There's the usual fear of infection, disability, and death, not only for themselves, but for others. And the whole issue of having family members who are unvaccinated, who are unprotected, and who have to take care of elderly parents, other generational folks. Then there's the stress of social isolation, inadequate social distancing at home and work. Many of our folks don't have a choice in terms of their living situations, in addition to work, being able to distance themselves from others. And then there's inadequate food. There's still too many places in this country that are food deserts. I didn't appreciate the term so much that I was out in Texas, found out wealthy communities, but didn't have grocery stores. And I said, what the heck? Then when I came back to DC, found the same phenomenon. Then, of course, there's the risk of job loss. Folks will be fired on the spot. I mean, I had the kind of union or other protections that other groups have. And many of us are one-step generation from poverty. And so the kind of job loss can be a financial disaster for the family. And then there's the stress due to working, providing childcare, homeschooling, if folks had the resources to do it. Next one. The consequence of overcrowding, not only overcrowding at home, but also mentioned later, we are disproportionate in our correctional system, as well as other institutional settings, much more likely to be institutionalized in mental health systems than other groups. And as a consequence of, again, social distancing and isolation and stigma. Two kinds of stigma. In our community, stigma of having the disease versus stigma of being believed that you're doing things like masking, which for some folks is stigmatizing. Then there's a lack of trust in public health measures and politicians, clearly mixed messages depending on which state you're in, or in a blue state or red state. Clearly folks have politicized this. And there's distrust around vaccinations. I'll say more about that. And this is not new, lack of quality healthcare in many settings. Next one. This borrowed this from Dr. Chapman. I love this slide. It's usually a chance I get. But point it makes, of course, is that there's emotional, painful history of Africans in America, as well as the recent events in terms of the legal issue, in terms of whether or not we are treated in the same way as the criminal justice system. Next one. So there's a reality of history, racism and its consequences, as well as disparities in access to care and support that's exacerbated, of course, by the history of racism in this country. Next one. And what we find is that, as noted, diabetes and hypertension more likely to be related to mortality from this disorder, and of course, more common in African Americans. Most importantly, more commonly African Americans are less likely to have ongoing treatment, and more likely to be in high-risk settings, jails, prisons, especially in poor communities. Those make hard decisions about whether or not they're going to do what they can to protect prisoners versus the general population. And then high-risk situations. So African Americans, less likely to be vaccinated, surprise, surprise, less likely to survive. And many folks in the community are aware of this. Next one. So we also face the consequence of loneliness. Loneliness is associated with depression or anxiety, often misdiagnosed, never diagnosed, and never treated. Also contribute to the belief that suicide and depression are rare in our community. And on top of that, lack of community social services, which contribute to morbidity and mortality, limited housing options, low income, the whole issue, the high rate of crime in some of our inner city areas contribute to further isolation. And then there's tremendous misinformation in terms of treatment. Next one. And which problems are more likely to worsen? Well, alcohol and other drug users have worsened. Domestic violence, because of isolation and quarantine and proximity, domestic violence has increased substantially in many homes. Grief and depression, very much there. The problem is not so much that it occurs, but it is unrecognized and untreated. And anxiety disorders, especially obsessive compulsive disorder. People who not only are worried about making sure their doors are locked, but they're worried about whatever they touch, whatever they contact. And if they have an underlying obsessive compulsive personality, these problems are exacerbated. And then for personal protective equipment, many people don't have it. And so what they do is they create their own personal protective environment by not going outside, not shaking hands, now not shaking hands with people, but not encountering other people. And then there's the usual financial problems, problematic access to basic health care. I'll say more about that later. Next one. And not only that, in the past, we got through slavery, we got through segregation and so forth, we had protective institutions for African Americans that were very helpful. The church served as a tremendous support in terms of other times of difficulty. But what has happened is many smaller churches have had to close. Folks have developed a number of different ways to address this. In the summer, it was pretty easy. We had churches outside under a tent, but I would find as well as cold as some of the other churches, that may not be an option. Also, funerals used to be that was a time when folks would bring the community together to address the support, needs, who's still hanging around, gossiping and so forth. And yet, and I just had a meeting of funeral directors. Now, the funeral is actually becoming a source of concern because it was never a place where folks could be a high spreader. Barbershops and beauty parlors. I know seeing folks who had beards, I didn't know had beards because of the fear going into a barbershop of being able to be around people who were infected. And I just said a friend of mine, the barber, had his whole family infected. And the community is small and unfortunate. They didn't have a barber for a period of time. So barbers, beauty parlors, which are important in terms of useful information and useful support of the community, weren't available. And the good old corner stores, small businesses are now under tremendous stress right now, despite federal funding to try to get access to it. Many of our corner stores simply don't have the resources to be able to apply for those grants. Schools, very controversial issue. Families that have the resources to do homeschooling, doing well, but there are whole communities that we have that do not have access to the internet, which creates a substantial problem in terms of schooling, as well as the politics. Should the kids get vaccinated? Should the kids, and the teachers will say, yeah, get vaccinated, because the teachers themselves are at risk. Even if the kids may not have as much problem. Then access to mental health services. The problem of access to mental health is a long-standing issue in this country. 50% of all folks, at least 50% of all folks who have mental disorders, African Americans, simply do not have access or are not being provided adequate mental health services. Next one. And when we look at major disorders, what we find is that the disorders themselves are a source of not only risk for COVID, but also spreading. Bipolar disorder, by its nature, involves folks who have aggressive and going out, having a lot of contact with others, participating in high-risk behavior. I'll say more about depression, but I'm also seeing a lot of panic disorder.
No, I'm sorry.
Having an outbreak coming into the emergency room when they feel emergency room is okay, compared heart attacks and affect their panic disorder. Not only free for anxiety, and I'll say a little bit more about PTSD, and also folks who have early onset Alzheimer's or even late stage, real problems in terms of the caretakers and family members in terms of doing what they can to manage the disease. Next one. I just mentioned actually work by Dr. Satcher, who looked at mental health and cultural race in this country, and supplements showing, next one, that there's a problem that we tended to be the risk of mental disorders is pretty much the same across all ethnic and racial groups. We are grossly more likely to be overdiagnosed with schizophrenia because we're just not recognized as having depression, bipolar disorder, or post-traumatic stress disorder. Next one. And this is just showing you that the whole idea of depression is that some people become sad and depressed because they got all the material possessions they have and they know they should be happy, but they're not. And they also may be chronically anxious. Next one. And part of the problem has been that for many of us, when we are depressed, we do not express sadness. And we show the lack of interest and pleasure in daily activities, weight loss or gain, sleep problems, too much or too little, lack of energy, inability to concentrate, feelings of worthlessness or guilt, and recurring thoughts of death or suicide, even if they have no thought of wanting to commit suicide. And many of these folks are persisting should be involved in treatment. The American Psychiatric Association now recognizing that even chronic long-term grief is a condition that should be treated rather than simply try to have itself resolved on its own. Next one. As I mentioned, it's problem more spousal abuse, being in concentrated places under chronic anxiety or stress, much more child abuse and suicide. Next one. Next. And it's just two books, John Williams emphasizing the degree of depression, bipolar disorder exists in our community, and it's simply not recognized. Not only not recognized, but folks are denied that we are even capable of developing these disorders. Next one. And now that, not only depression, but also tension, anxiety, chronic fear, and folks that have frank terror. What are you scared about? Oh, nothing. That's Corona. I don't know. A sense of impending disease, doom. And all folks become numb and just go through frank denial. That's what. Next one. This is a case of a 48-year-old female patient I had who was unvaccinated, ended up in a ventilator for 30 days. And she came out in multiple stress. The stress was not just the ventilator in which she was semi-conscious the whole time due to medication, but because she had a sense of helplessness, confusion, feeling of prodding, difficulty breathing, flashbacks, and afterwards, for months after, continue to have nightmares, dreams of drowning, and frank phobia in any enclosed environment. Next one. This is also excellent work by Dr. Prasant Alexander, emphasizing up until that time, we thought that Black people didn't commit suicide. Next one. Now we know, of course, that we do. Next one. We are now seeing that there has been a surge of drug overdoses and suicides. And again, I'm not going to try to figure out how many of those drug overdoses are real suicide. Point is that what we're doing is we're finding that suicide rate for young Black men is increased substantially, and that it's one of the largest rates in any ethnic group. And it seems to be co-occurring with the emergence of COVID. Next one. And again, in terms of the later in the ventilator, a lot of folks are experiencing post-traumatic stress disorder, like soldiers in combat, which they have flashbacks, jump at anything, and avoid behavior. Next one. And the main problem is that treatment is delayed or refused. Novel treatments and research are viewed with suspicion. And unfortunately, people are turning to alternative treatments such as drugs of abuse, which is leading to even other problems, as Dr. Chapman has emphasized, so that the death rate for drug abuse go out into the thousands now. Next one. Next one. So why do people use drugs? Feel good, but also to deal with ongoing anxiety, worries, fear, depression, and hopelessness. Not just dealing with pain, not just dealing with sensation seeking. Next one. And as a surprise, what we find is that psychiatric evaluations actually declined during the COVID period. And of course, outpatient treatment became more used with telemedicine and then with family court operations. So that's good news, right? Well, wrong. Next one. The emergency rooms visits declined, but we had a big jump, of course, was in drug abuse rates, 29% increase. Part of it has to do with the availability of fentanyl, 100 times more potent than heroin. People are using these drugs to deal with both psychological as well as physical pain. And it's been an atypical surge in Black Americans. Dr. Chapman did an excellent job in presenting this, so I won't say much more about it, except this is an ongoing issue. Next one. That's again showing you that it spiked when we started pandemic and stayed high for prescribed and illicit drugs. So it's not just the prescribers, there's more drugs being prescribed, but also folks also illicit use as well. Next one. Next one. And again, one approach to deal with drug abuse, unfortunately in this country, if it's not prescription drugs, of course, put people in jail, which is increasing the likelihood that they're going to again become more exposed to the stress of COVID exposure. Next one. So how do we deal with this? Do you want to use treatment or do you want to use rehabilitation? Do you want to use punitive methods or we want to try to deal with these problems with treatment programs that are evidence-based? Next one. Well, good news. Most of the treatments for mental health, mental disorders, substance abuse work. Problem is Black folks can't get them, but they work. Next one. So, in the same way with vaccines, we now have effective vaccines for the time being at least, and we now have non-vaccine, other agents, other than vaccinations that are available, but they're less likely. Why are they less likely, especially since the vaccines are free? Next one. Well, part of it has been myths that circulate in the community. I think Dr. Jordan tells an excellent story about students who are told that they don't get the vaccine because of the Tuskegee study. And yet when you ask folks what it is about, they don't seem to recognize it. They see that it was not a deprivation, not trying to give people treatment. It was a deprivation in treatment. And women for group marriage just run a list of different kinds of reasons why people shouldn't get vaccinated, all the way from magnetism, sexual dysfunction, impact on the fetus, and of course, somehow we have technology to put monitoring devices in vaccines. Next one. So I just want to get mentioned, does not cause you to be magnetized. is not mentioned in the Bible, despite how folks go around saying it's the mark of the beast. And I still don't understand the monitoring device explanation. Next one. And one approach that we need to do, so I just can show well, is that, again, we need to get more of us involved in terms of the clinical trials for the new treatments, free treatment, and as well to expand the options for treatments. But what we unfortunately are finding is that African Americans still are underrepresented in terms of new treatments for a variety of reasons. And I want to emphasize this, and other studies show, it's not because we don't want to participate in treatment, often because we don't get the opportunity to be requested to participate in clinical trials. That's it. And again, this is just showing some data from Dr. Chapman's group, showing that when we look at behavioral health services in our local area, this is a group in Northern study that simply found that the folks had a lack of access to behavioral health care services, housing, food, transportation, clothing, furniture, all these factors contributed. Next one. And then when we looked at percentage of people who had PTSD and major depressive disorder in our primary care clinic, and again, found that only 17% were treated or referred for mental health treatment in folks who had clear-cut mental health needs. Next one. So part of our challenge is to get folks into treatment. We gotta look at what kind of answers do we have. Gotta look at making omelets out of broken eggs, lemonade out of lemons. Gotta be creative. And Zoom technology is one that we really need to expand it in terms of our basic psychosocial support. Next one. So we gotta encourage positive health behaviors. One of the unexpected consequences of the Corona crisis that people are simply not getting the positive health behaviors that they should be. And often we find a lot of folks don't have options in terms of stress and frustration. Next one. Next one. So we got to do what we can to preserve, I think, working through our social institutions that worked in the past, as well as looking at community organizations, mass demonstrations, disparities in resources and care that continue to persist in our community. Next one. Next one. Here's just some institutions that can be initiated: AA or NA exercise, mindfulness, relaxation therapy, CBT. I actually had a debate about folks who say, well, we don't know if CBT will work on African Americans. Yes, it does. It's cognitive behavioral therapy. To reduce time watching the wrong kind of news, maintain a positive outlook, and listen to the recommendations on real health experts. Next one. Social ties associated with positive health behaviors, community groups that's focusing on diet, exercise, and regular medical checkups, as well as opportunities for stress reduction. Next one. And it's just some organizations: National Alliance of Mental Health, Illness, Mental Health America, various telehealth services, wellness guides that are being available, several professional organizations: Black Psychiatrists of America, Association of Black Psychologists, Association of Black Social Workers, which are actively involved in terms of expanding knowledge and awareness of mental health services in the country. I think that's the last one. Yeah, that's it. Okay, much needs to be done, but promised land is in sight.
Dr. Lawson, thank you. Thank you so much. You were able to give us a tremendous amount of information in a short period of time, and we really appreciate it. We absolutely are going to continue to follow what's happening with mental health in our community. So much of it is not talked about. So we really appreciate your leadership in doing the work, doing the research, creating the information out of research, gathering it for us, and coming to talk to us about it. Dr. Neighbor Stevens, are there any quick questions in the chat? I know we want to move to understand how fast we have to run to get away from Omicron.
At this point, there are no questions in the chat.
I do have a question. And your slides were quite interesting to me, Dr. Lawson. Is there any relationship between the stress of feeling unprotected, the stress of the pandemic and the virus, and one's physiological vulnerability to the virus? Is there a cause and effect relationship?
Yeah, I don't know if it's a direct cause and effect, but I think there's strong evidence that some of the neuropsychological consequences may be related. We've got some research showing that post-factors that contribute to post-traumatic stress disorder actually results in physiological changes, for example, in the hippocampus, that's associated with persistent PTSD. So then also there are others who are doing immune, looking at the inflammatory processes in the brain that may be related to high risk for depression. And we're involved in a study now, which we are looking at the people's ability to use olfaction. And we'll find that if you look at the olfactory capacity, that we can look at as we're actually doing some treatment for substance abuse. So
Okay.
yes, there's a lot of suggestive evidence. Technology is moving in a direction to show that I think we're going to find more evidence that these kinds of stress-related factors can result in long-term changes in key brain structures.
Well,
There was a note in the chat asking, and Simon, if you could put back up the slide that had the resources while I asked Dr. Lawson a question really quickly. Dr. Lawson, you mentioned that there are fewer resources in the African American community in some communities, and that's why I think the request was made for that last slide to go back up. If we can't do it, that's okay. But Dr. Maxey, is there a way for folks to get access to that information? Can we put it on the Black Health Trust site?
We can do that.
Okay.
I'll get with Simon after that, and young people advise me on how to do it.
Okay, Dr. Lawson, just real quick. You also mentioned that
Is that the slide?
I think that's the one, the resources slide. Yes, thank you, Simon. Dr. Lawson, you mentioned that African Americans aren't as likely to be involved in research, and so much of the important work that you share with us comes out of research. So how do we encourage folks that look like us to get involved in the research so that it's relevant to our communities?
Yeah, I think this forum right here is a great way of doing it. The NMA has Project Impact, which has been dealing with that issue. Dr. Walt Faggett has been actively involved in terms of clinical trials. And the bottom line is if all of us can be involved in some way. You don't have to be the principal investigator. You don't have to be a surgeon. But what you can do is encourage people when they hear about these trials, they'll ask, they will come to us to ask, is this something I could be involved in? Or is this an insidious plot to exterminate all Black people? Encourage people to look at them. I'm still always amazed when I talk to my friends at Johns Hopkins and they say they can't find Black people. So we need to do what we can to be able to encourage folks to say, when these opportunities come by, one, it's a way to get free evaluation, free exams, and free treatment. And two, be right at the cusp of finding a new and effective treatment that could change the course of a significant disease state.
Well, thank you. Thank you very much, Dr. Lawson. Just a plug for the psychiatric side of the house. We may find some people that don't have diabetes and don't have high blood pressure. We're not going to find anyone that doesn't have some mental health concerns that need to be managed, protected, or addressed. So it's for all of us. Thank you so much, Dr. Lawson. Appreciate you, man.
Thank you, Dr. Lawson. That was wonderful. And Dr. Walks, thank you for inviting him to the program. As usual, you are a superstar as well. Just before we go to our next speaker, which I'm going to ask Dr. Nabret to introduce him, we're going to try to have a medical advisory meeting, if we can, this Wednesday in light of the new things that are happening. And hopefully Dr. Walks will chair most of that session with our advisory committee on vaccines and do that. Dr. Nabret-Stevens, would you introduce Dr. Despani, but precede that by some of the vital statistics that we need?
Certainly, it's my pleasure. So as usual, we try to share data that is present on the CDC website, on the CDC tracker. Actually, to my surprise, when I went to the tracker, they have a lag in updating because of the holiday. So the first three numbers that are groups that I talk about will be updated through yesterday. But the vaccine information is old in this day and time. It goes all the way back to Wednesday. So the total number of US cases since the pandemic began is now logged in at 47,916,623, with 11.7% of those cases being represented by African-American subjects. The total US deaths at this point are 773,779. I kind of want to underscore this is the official tally. Most people assume this is an underreporting. Of that number, however, 13.8% are represented by African Americans. And then finally, as of last Wednesday, the total number of people who have been fully vaccinated, and at this point, that definition does not include the booster population, is 196.2 million. And the rest of the data, I'll have to update us on next week. So moving on, this is I won't say a command performance, but certainly everybody wanted to hear from Dr. Despani. Dr. Despani is well known to the regulars on our program. He is an entrepreneur and medical communicator that is driven by the challenge of addressing complex problems through biotechnology, and I might add data. He obtained his BS in biology from Louisiana State University, where he conducted research on coronaviruses way before it became the topic of the day. He has investigated the molecular biology of cystic fibrosis and earned his pharmaceutical sciences PhD at the University of Southern California for his dissertation work developing chemotherapy drug carriers to combat triple-negative breast cancer, an aggressive disease primarily affecting young Black women, which I hope you will recall we had a great discussion about a few weeks ago. So without further ado, I'd like to bring on Dr. Despani.
Hello, everyone, and I am continuing my ongoing virology seminar as a part of the Black Health Trust. This would be entitled Virology 501, and the subtitle is Our Greek Lessons Continue. So firstly, we have to first acknowledge that a new challenger has arrived onto the stage of history, and that's the Omicron variant, which was first identified on November 11th in Botswana, which is a landlocked Southern African country that actually borders South Africa. And it actually is now spreading rather rapidly through South Africa, and it actually seems to be outcompeting prior variants, where in South Africa, we typically see that Beta and Delta are the top variants, but based off of the data that we're seeing thus far, Omicron is moving far more rapidly. And even though that is the case, let's have some sense of proportionality, namely the fact that there have only been a total of 141 cases, but again, 70% of those cases actually do derive from South Africa. And another thing that should be pointed out is that some of these cases have been reported in those who have been previously vaccinated. As of the data that I saw most recently, there were 4 cases in Botswana that were in the previously vaccinated. And there was also a case of a gentleman from Hong Kong who was vaccinated, and he still had developed the Omicron variant. So now we need to move on to just considering the Omicron variant at a glance. And what you can see here in this first little top panel is a genetic map or representation of the Omicron variant, which with each of the point mutations that are key to understanding this new variant. And in tandem with that, one needs to ask 3 key questions, which are, is this more transmissible? Does it cause more severe disease? And will it render our immune defenses less effective? So that's what clinicians and public health officials are all considering. And we can't know any of that a priori because, again, we need to conduct the requisite studies while also seeing it basically more in nature. But one thing that we can rely upon are the biochemistry and biophysical studies, as well as what we already know about prior variants. And what's has a lot of people very concerned is the fact that this has 50 different point mutations, which are very, very, very concerning because for prior variants, we maybe saw a total of like maybe 10 or 20 point mutations and whatnot. So to have like such a precipitous jump is a concerning sign. And that also points to the fact that South African scientists did a masterclass in alerting the world so quickly so that we can be at the head of the pack in terms of responding to this, as opposed to being at the back as it has occurred with the original parent virus, as well as the Alpha variant, Delta variant, Etsy-Coral. And one thing that you can see in this table on the right is that a lot of these point mutations are actually just being conserved or alternatively just evolving spontaneously in viruses or viral variants from the SARS coronavirus 2 family that are happening independently of one another. So they're not say like going in a clear lineage, rather, they're all just spontaneously evolving these point mutations. And as you go down this table, you do see that, again, the Omicron basically was like a paradigm shift. But one thing that we can leverage, again, are the fact that we know about some of these mutations from, say, the Alpha variant, the Beta variant, Delta, and Mu. So for instance, we know that E484K as well as K417N, which appeared in beta as well as gamma, actually facilitate antibody escape. So this basically means that even if a person is vaccinated, the virus can actually cloak itself and, just disappear, and it will no longer be recognized by your antibodies, regardless of if you have developed the immunity through natural infection or if you've been vaccinated. Another important point mutation is N501Y, which is what allows the spike protein, or one of the point mutations that allow the spike protein to bind more tightly to the ACE2 receptor. So it's kind of like more powerful Velcro so that it can just stick to your ACE2 receptors that line your respiratory tract, and it's actually found pretty predominantly throughout your body because it also is on vasculature and whatnot. And the fact that SARS coronavirus 2 targets that ACE2 moiety is the reason why it causes all of these variegated effects, right, in terms of cardiovascular concerns and respiratory concerns. And then lastly, we also have P681H, which has been illustrated to allow more rapid transmission in hosts. And the reason why is basically because it acts like molecular scissors to cut the enzyme that actually cuts a certain part of the spike protein, and then subsequently allows entry into the host cell. So yeah, it's very interesting in terms of its biochemical profile. And as you can see here on the left with the map of the countries that it has actually spread to, and it's actually should be updated. That's like a lagging indicator, unfortunately, because it was also recently found in Australia. So the reality is that this variant is indeed moving as quick as, if not even more rapidly than the Delta variant. But the reality is that this is not a time to panic and whatnot. Let's see what the data indicates, because we have information from prior variants, but we can't just go into full-on panic mode without knowing specific aspects about this variant in particular. So another thing that I wanted to do is illustrate so you guys can get a beautiful snapshot of the Omicron variant itself. Like, isn't that like just a very pretty picture? And you see specifically the spike protein, which basically is a trimer. Trimer basically means that it has 3 portions. And one bit of good news from the biochemical side is actually that there is a mutational deletion that's at 69 to 70 in the spike protein. And that actually allows us to detect Omicron more rapidly. So one of the things that is I guess a small impediment to identifying what variant patient is infected with is that the clinician or scientist has to actually perform what's known as whole genome sequencing, where going nucleotide by nucleotide or like letter by letter to identify, okay, this is alpha, this is beta, this is delta. Whereas thanks to this deletion in Omicron, we can actually use the standard test, which is basically qPCR, that's quantitative polymerase chain reaction, to immediately identify that, okay, this is Omicron, we know what to do. So again, one must always consider that even though these variants emerge due to evolution and natural selection, it's a random or stochastic process whereby it has some things that benefited in terms of being able to infect people more rapidly or evade our immune defenses. But at the same time, it also evolves mutations that might be leveraged by us as tools to more rapidly engage in diagnostics. So it's a random process that we need to leverage to the best of our ability to fend off this variant as it spreads. And probably one of the most important questions that many people are asking is, why do these variants keep emerging? Because it's basically a fusillade of variants. After the original parent virus, we got hit with alpha, we got hit with beta, we got hit with delta, which became another big one. And obviously this is leading to fatigue, which, as Dr. Lawson mentioned, right, it's almost tantamount to post-traumatic stress disorder, except that this is happening at a societal wide scale. And the reality is that these variants are actually evolving for 2 reasons. One, these viruses or the variants are actually incubating, for lack of a better term, within immunocompromised individuals. And this could either be due to the fact that this is occurring in a medical setting, or it could be that the person might have, like, say, HIV-1, which Dr. Wilbert Jordan is a specialist in. And if they're not diagnosed, then they're basically just serving as an evolutionary training ground for the virus to come up with all the mutations that it needs in order to evade the T cell response, the B cell response, and just get better at infecting the next host. So again, it's really like going to like a practice prior to a big game, and that's basically what the SARS coronavirus 2 is doing. And then eventually you got to Omicron. And then secondly, the other aspect is that there are insufficient vaccination rates across the world. So the reality is that while we have high vaccination rates in, say, the developed world, and developing world, you're maybe topping out at 30% vaccination rates. And that basically means that the virus has a whole world of hosts in order to infect without worrying about anything, because those hosts are basically immuno-naive. They've never experienced this before. So the virus is like, okay, cool, great. This is a great way to jump in and move forward in my transmission chain. So it is very critical. And then, as you can actually see in this figure from medRxiv, the reality is that even though the vaccination does not 100% prevent a person from never ever getting infected, the reality is that by putting up immunological defenses within your body via vaccination or prior natural infection, what happens is that makes it more difficult for the virus to adapt within the host. But if a person is not vaccinated at all, it's basically like a roll of the dice, with the caveat that if you're just rolling the dice, there also is a fear that you can develop long COVID or you just might die. And just to further emphasize the vaccine inequity, or I've even heard it called vaccine apartheid, the reality is that even looking at a map here, you can see that the developed world has the lion's share of the vaccines. And again, that includes things like Moderna, Pfizer, J&J, Etsiporo. Whereas if you look, say, in Africa, which again, previously the Beta variant was identified in South Africa, and now the Omicron variant was identified in Botswana, you see that if you don't have sufficient vaccination rates, and again, the world total has only had approximately a 34.3% vaccination rate, then you're basically providing a playground for the virus to continue its evolution. So the reality is that vaccinations need to be distributed to emerging markets at higher rates, and until everyone is protected, no one is ultimately safe. And just to review what this means for our progress, I'm using a figure that I used in one of my prior presentations for the Black Health Trust. And the reality is that we often use what's called R0. R0 basically is a number that determines if a person gets infected, how many more people will they go on to infect. And by the time we got to Delta, one person could end up infecting like 6 other people, and that led to a very high R0, and that meant that you needed to have basically like 83% of the population vaccinated. Which I should clarify, in the United States, we have only just tipped over 59%, so we're approximately at 60% vaccination rate. And as a bit of good news, though, from the data that is coming out of South Africa, the R0, or reproduction or replication number, is about 2. So that's slightly encouraging, but not really, because the way that this number works is that if you have an R0 that is below 1, that means that the pandemic or the epidemic is self-limiting. It's not going to spread. If it's at 1, it's in a state of equilibrium. If it's higher, then that means that it's spreading. So that's where we are. But if we can engage forcefully in combating this Omicron variant, then we can have a chance. And just to clarify something that Dr. Fauci doubtlessly has dealt with, is in communicating all of this to the media and the world writ large. The reality is that herd immunity is not a stable thing. It's not a fixed like 1 or 2 or 3 or 4 and whatnot. It changes because it depends upon the dynamic nature of how humans behave and whether you're masking up and are you going to a super spreader event like concert or some such during a pandemic, as well as viral evolution. So it's a kind of like equation, a balance equation. It always changes, it's dynamic. And that's the whole reason why herd immunity is ultimately an evolutionary moving target. And this then brings to the fore the question of how our current armamentarium stacks up against this Omicron variant. And what you see here are the vaccines that have been approved, which include Pfizer and Moderna's, as well as AstraZeneca's and Johnson & Johnson. And one thing that's expected is that while there will be some reduced effectiveness of our vaccine efficacy, it won't just magically go from, say, you had 80% vaccine efficacy to 0, right? That's just too precipitous of a drop. And that actually is a reason why a person should get a booster shot, is because you're actually reawakening your immune defenses. And again, if you do encounter Omicron, then your immune system will know how to react to it, as opposed to if you're immunonaive, then the virus can just run roughshod over you. And then another thing that should be mentioned is that, again, because AstraZeneca and Johnson & Johnson leverage different technology relative to the messenger RNA technology, they use viral vectors. They probably would perform less effectively than the messenger RNA vaccines. But again, it's a balancing act, because holistically, some people may not be good candidates for receiving the messenger RNA vaccines because it may be too reactogenic. And reactogenic is just a term that means that you get the shot and then afterwards you feel like 85,000 bricks hit you and you're just not getting better, or you might develop some other untoward effects and whatnot. And again, same thing can happen with the AstraZeneca or Johnson & Johnson, but it's a balancing act of figuring out what's the person should receive. And then on the other hand, we also have in our armamentarium both antibodies as well as small molecule drugs that are pending FDA approval. But the problem that we know, especially with Eli Lilly's bamlanivimab, is basically that in having given this antibody to so many people, the virus, and this wasn't even Omicron, this was most likely a Beta or Delta, the virus actually evolved a way to invalidate those antibodies. So that's definitely a problem to consider. But again, keep in mind that this is just an evolutionary process, right? That's the same mechanism behind why antibodies can eventually no longer be effective against the variants, is the same process that is at play when a person develops chemotherapy resistance, or whenever a person develops antibody resistance, and et cetera, it's the same process at play. So that's why science often dictates that when a person, or whenever a treatment is administered, it should be in a combinatorial approach where you're hitting it from 3 angles as opposed to 1. And then I just also wanted to point out that with Pfizer's Paxlovid and then Merck's molnupiravir, those are antiviral drugs that they are both going before the FDA, and they will probably be approved by the end of this year, if not Q1 2022. And those, again, are they add more bullets in our armamentarium, for lack of a better term, but we can't rely exclusively on the antiviral drugs, because again, eventually the virus will find a way to evolve around those those antiviral drugs. But there is more help on the way, so to speak, in terms of now being able to add antivirals as well as antibodies and vaccines to our total arsenal. And the question inevitably comes down to this: how can we combat these variants? And it's the exact same things that have been mentioned beforehand, which is that people have to continue getting vaccinated or get a booster. If you've been vaccinated previously, you need to continue wearing masks, and you need to practice pragmatic social distancing. So even though we keep having to deal with more and more variants that keep coming on like a hurricane, so to speak, the tactics that we can leverage here in our homes, in our communities, and the global village croquet is to basically do the same tactics, right? It doesn't change. It's just a matter of having resilience to get through this. And I did want to quickly go through some studies that have actually been done against prior variants, and just showing people, like a visual representation of like the data. And what you can actually see in this study here is that as we deal with certain variants that are more capable of evading our immune response, the neutralization levels drop. And the way that a person should like read this chart is to consider that the neutralization basically is how effective your antibodies are at basically binding to the virus once it's in your body, and just like grabbing it and saying, get out, you're no longer welcome in this house. And at the top where it says convalescent sera, that's basically in those who did not receive a vaccine or anything of the like, but they basically develop antibodies following natural infection. And then below in C, you see people who again have like antibody levels after receiving the Pfizer vaccine. And one thing I did is I made this interesting zigzag type of downward arrow, because the way that antibody neutralization and just antibody levels work is they don't just drop like a rock, like in a linear ratio. Rather, it's typically more stepwise. And what you see here, just generally across these variants, is that against the parental virus that originated around Wuhan, we have a solution. But then once you get to the variants that have immune evading point mutations like beta, as well as mu, really, those are like the best at immune evasion, then you see that the antibody levels drop, because basically those specific viral variants have ways so that it prevents the antibody from actually being able to bind to it. So it's just like, you can't catch me, and then it just disappears from the immune system. So I mean, the reality is that as variants evolve, that antibody dependent neutralization will drop in like a nonlinear manner. And that's regardless of if you have natural immunity from being infected previously, or rather you've been vaccinated. So that's why we're worrying about Omicron right now. But again, this is not all bad news, right? Because we have data that has specifically shown that boosters augment antibody levels. If you will look with me at this data here, you see that on the left, like in the 18 to 55 age cohort, before like any dose of the vaccine, and for this one, this was the Pfizer vaccine, there's no antibody efficacy or any neutralization, right? But then after you get your second dose, now you have like a wonderful response rate, but then it starts to drop slowly but surely as time goes on. And then once a person gets that booster shot, bam, it goes right back up, and it will drop again, because not all, I guess, viruses and whatnot can be developed into vaccine candidates that will induce lifelong immunity? Because I know that that's one of the biggest things that many people ask, like, oh, how come we can get like a lifelong immunity from, say, something like measles, mumps, and rubella, but not, say, SARS coronavirus 2 or influenza virus? And that's just the nature of them having RNA genomes, which basically means that they mutate far more rapidly. And you see the same trend in the 65 to 85 age cohort in terms of receiving the third dose actually like enhances their antibody levels, but obviously it's at a much lower rate, if only because, again, they have undergone what's called immunosenescence, or aging of the immune system. And the good thing is that Pfizer itself recently stated that they plan to have an Omicron specific vaccine ready for FDA review within 100 days. So that's a little over 3 months. So again, it's really like we're entering an age where a person, just like a person can have like a modular, not a modular, but in a way, a modular cell phone that they can upgrade, like the iPhone 11, blah, 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 blah. We're getting to a point where we can have upgradable vaccines, which, again, Edward Jenner, who actually invented the first vaccine for variola, aka smallpox, he would have never envisioned that whenever he was doing what he was doing in the 1700s. And just this is the final slide. This basically just reviews how SARS coronavirus 2 infection occurs, and at the molecular level, and how the mRNA vaccines work. So basically you have the SARS coronavirus 2, which looks like a little spiky soccer ball, and it binds to your ACE2 receptors, which are, again, studied all across your body, but most predominantly for the virus in the nasal and the nasal cavity, as well as the lungs. And it binds directly to those ACE2 receptors. But what you can actually do is you can leverage the power of modern science to basically get a shot with a synthetic version of the spike protein. And the spike protein is what actually is used by the virus to bind and stick to your ACE2 receptors. So again, you're making a synthetic version of that spike protein. And then, like, your body is going to recognize that spike protein and eventually activate your adaptive immunity after 14 days, mind you, so 2 weeks. So it's not instantaneous, but then that's what actually allows your body to build up an arsenal of antibodies and both cytotoxic and helper T cells, so that they can all recognize as sentinels, or basically like intracellular terminators, to just go in and attack and destroy. And the whole thing too is that even though Omicron is a new variant, it's still SARS coronavirus 2. It still belongs to the same family. So there's a high likelihood that having vaccination or prior immunity will induce some type of recognition, but not total. So again, a person should be careful, because this variant most likely can cause breakthrough infections, but at the same time, it should not, if you've been have some type of previous immunity, it should not totally like obviate or reduce you to square one in terms of being protected. And that's all.
Could you put that slide back up, please, Jordan? Because we've got a number of questions that probably that slide will help understand.
Okay, am I still sharing?
The first one is coming from Facebook, I'm happy to say. And our listener wants to know, is it true that Omicron variant originated in an immunocompromised individual? And if true, how do we combat this finding if immunocompromised individuals are not developing an antibody response to the current vaccines that are available?
Yes, that is the leading hypothesis. We cannot confirm it until we have a patient 0 that we can run sequencing results. But that basically is the hypothesis that is in vogue. The reason why, because we have seen this with alpha, we have seen this with beta, and that's most likely where delta came from as well. And the reality is that it's really tough. I mean, that's why even before booster shots were made available for the general population, that the immunocompromised population was given a third shot of that full dose to the first and second shots. And the reality is that that is kind of why we need to protect the immunocompromised individuals. But again, how can one do that if, say, it could be someone, say, that might have HIV-1 and they don't actually know that they're infected? That could very well be the case. It could be a co-infection. So the reality is just that we need to act like sentinels to one another and engage in community by all performing our duty, our task and responsibility of getting vaccinated so that we build up our immunological defenses so that when we get infected, it's so much harder for the virus to evolve and transmit to someone else that protects the most vulnerable people in our population. And on top of that, we also need to get more vaccines into the rest of the world, right? Because now we're seeing that in places that only have, say, 30% vaccination rates, like, say, India or South Africa, that these variants are evolving and then coming back as like a sort of backlash to affect us, even though we are trying to do everything that we can. So again, it's until everyone is safe, no one is safe. But the reality is that we need more vaccines, and we just need to keep our immunocompromised population protected.
Now, on one of your slides, you had 3 strategies.
Dr.
This is from
Neighbor,
the chat. This is from
I
the
think
chat.
Dr. Hines had a question.
Can I put the chat question out?
I think Dr. Hines had a question, I thought.
No, I can wait till Dr. Neighbor Stevens finishes, and then I was just going to go through some of the questions in the chat on the Zoom. So, yeah.
Okay.
So you had the slide that had the 3 approaches to manage as our armamentarium.
Mhm.
So the question in the chat is, do you think that perhaps the antiviral medication strategy may be more effective than the vaccine strategy in the end?
No, I think that that's like an either or choice. We can't do either or choices. It's the same thing if you came to me and I actually was like an oncologist and a person said, oh, like this person has triple negative breast cancer. Should I only use should I only use surgery, or should I only use chemotherapy? No, like you have to take a combinatory approach. The way that viruses and cancers and bacteria and even humans work is that we are affected by multiple things simultaneously, right? Sunlight, blah, 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 blah. And in this case, for us to combat the virus most effectively, we need to be leveraging the antivirals as well as the vaccines, as well as social distancing, as well as masks, et cetera, right? The world is too variegated to just only try one strategy, because the problem is that if you only use like the like either Paxlovid or molnupiravir, those act through the same mechanism of action. What they do is they integrate into the virus as the virus is trying to build itself, and they cause it to like stutter. It's like, I don't recognize this thing. What is this? And then it just self-destructs. The problem though is that they're all using the same strategy. So then the virus is like, hey, I know what you're doing. I have a cousin here like named Omega, and he'll handle you. And that's the problem. So you need to put so much pressure on the virus from different directions that it can't, like, oh, Omega, like it's trying to be born. Oh, no. You can't, because the vaccines are there. So you're going to have a harder time getting into more people. And for the people that, are in the earliest stages of infection, we can take the antiviral. And, for the people who, like say don't want to get vaccinated and whatnot, like they need to be very careful in staying at home, et cetera, et cetera. So again, humans also play a role in this. It's not just the virus.
So one of the other questions, there's another question in the chat, and the question is about, can the J&J vaccine be modified to address variants similarly to the way that you discussed for Moderna and Pfizer vaccination?
Yes, they can. The reality though is that it would take far longer.
And then there's a question. It is my understanding that Africa created their own vaccines and refused the US/Israel vaccines. If this is true, how effective is their vaccine to this new variant O?
To the best of my knowledge, I don't know about Africa having its own vaccines. I know that Russia and China have their own vaccines. But I still leave open the possibility that it is the case. I don't know. But the reality is that you basically need a vaccine that at least has the ability to cover some of the point mutations that are in, like, say, Omicron. So one of the things is that we know that, say, E484K, that point mutation, which like virologists lovingly call it EEK. So EEK is that's just not covered by any of the vaccines. And with Moderna was like, yeah, we want to come up with a new vaccine that covers this, because EEK was found in beta as well as I believe mu and right, at the very least gamma. It was found in beta and gamma, definitely. I'm not sure about mu, but yeah, it's an exquisite biochemical modification that allows the immune evasion. And the reality is that, again, if you're not covering that, then that's why you can have a variant that can just still cause an infection, because it's like, oh, you're vaccinated, but I don't need, like, I can just dodge your antibody, so you're infected again. So, and that's what we saw in a lot of the South American cases, where like these beta, gamma, and mu were just like infecting people again and again. And it's like, okay, so yeah, so we do need an update.
Can I just comment on the last question, because it bothers me. Now, hopefully, Africa has created their own vaccine, but let's just, whenever we hear something like that, Africa is not a country. Africa is several distinct countries with many distinctly different approaches to things. And whenever I hear somebody say that Africa did something and we don't need to help them, I don't believe it. I believe it's some sort of a trick to get us to stop looking at people that look like us and to stop asking that we take this worldwide approach. So if there is some combination of African countries that has gotten together and issued an edict, let's see that before we start telling everyone that we think Africa is doing something that clearly would result in a lot more Africans dying from coronavirus if we all agree that we don't need to send them any vaccine. Dr. Despani, I'm with you. I've heard exactly the opposite, that we need to get vaccines to the different countries in Africa and different places around the world. So this sounds like some more of that social media stuff that just makes me crazy, because Africa is not a country. Okay, I'm going to follow Dr. Lawson. I'm going to calm down now and get my mental health back in check. But
let
okay,
me actually
I'm
follow
done.
on with what you're saying, Dr. Walk. And this, anybody can answer this, but there were some 7 countries that the travel ban to the US was put in.
Yeah.
All in Southern Africa. They did not ban travel from other countries that are in North Africa, so to speak, in Europe. Why is it just the countries immediately next to and around South Africa prohibited from travel? That sounds a bit selective, being very nice.
Yeah, exactly. Yeah, and that's the other thing too, that firstly, I will parlay off of what Dr. Walter said, that, yeah, like I literally saw like the gentleman who actually published the data set on Omicron from South Africa. His name is Dr. Oliveira. He was just saying, Tulio Oliveira, he was saying, we need help now, like bring more vaccines and what have you. So it's a caner that, like, because I've never heard of any, African, like, vaccine specific and whatnot. And then secondly, the South Africans are specifically frustrated because they're like, hey, we did the world the good by alerting them to the fact that Omicron, like, this is a very, like, potentially like worrisome variant. So we let you guys give you a heads up, and your reward is to just like close the door on us and lock the key like behind you. Like what is that? It's very unacceptable, because again, like we can, like, especially the developed world, we can try to run away from this all we want, but this is not like, like, oh, like, is this faction against this faction because I don't agree with you and whatnot. The virus does not care. And the whole thing is that it can, everything that I've showed you guys, that's all lagging indicators, meaning that the virus is probably already somewhere, like Dr. Fauci said, it's probably already here. I mean, that was the case with the original virus. That's the case with alpha, beta, etc. Why is it not the case with this, right?
Right.
So,
But as a follow-up to that,
Mhm.
or in addition to those comments, which I wholeheartedly endorse, there is a question in the chat as to whether or not one should consider travel at this point to South Africa.
No, I don't think so. No, the reason why is because the case numbers are like going to multiply here. So the problem with like humans have this problem where they have a hard time thinking of like exponential growth, which applies not only to scientific cases, but also even to like investment. Like it's just like, for instance, for me, I put in my money and whatnot. I expect compound interest to make me wealthy, but I can't comprehend like, will I really be like that wealthy? And it's the same thing here, that when you see 141 cases, you're like, oh, that's easy. But remember that are not, right? So if it's 2, then it's going to transmit to, like, whoever was infected is going to give it to 2 people. And then afterwards from 2 is going to multiply, and then you start to really get the compounding. And then you have America turning red, like I saw to my horror with the Delta back from May to July. So yeah, I don't advise travel to South Africa, unfortunately, but at the same time, that does not mean that we should not help them. Like, let's treat this like an emergency medicine case. Like whenever someone gets shot and whatnot, like a person like would do what's called scoop and run, grab the person, immediately get to the hospital, and that's known as the platinum 10 minutes. It used to be the golden hour. No, it's the platinum 10 minutes. Right now, the countries of Africa, Botswana, South Africa, like just really like the whole like continent, if it starts to travel upwards, like that's they're saying help. This is the continent's platinum 10 minutes. And the reality is that it's already spread. Again, it's Australia now. Australia is not, like linked to Africa. So I would like to believe that the world will get up on its feet and do things, but the reality is that we've already been through this rigmarole before. Like this is what, our 4th time now, maybe 5th, and we have not risen to the challenge. So
let me go out on a limb a moment and take advantage of our 2 youngest members. If I were to be king of the world and appoint you, Dr. Despani, and you, Dr. Hines, as the Chief Health and Political Officer of the United States and the world, what would be the 3 top recommendations you would make to the world as of right now? First, Dr. Despani, and then Dr. Hines.
First would be increase our genomic surveillance of the virus and its variants. That is key. That America is lagging hard on that. Secondly, make vaccines more readily available. I mean, you don't have to give up your intellectual property, but at the very least, you should like rush shipments of that. Thirdly, really just emphasize the importance of social distancing. I know everyone is tired and whatnot, but the virus doesn't care.
Dr. Hines, physician from Maryland, head of is it the Family Practice Association that you're chief of?
The Maryland Academy of Family Physicians, sure, yeah. So I would probably, trying to be novel and not say the same thing that Dr. Despani just said, but I'd go with increasing feasible access to vaccinations, right? Because some of these things we don't have a good strategy for when it comes to getting people to be fully vaccinated. When you think about all of the logistics that are involved in getting to countries that don't have reliable, power, right? To refrigerate and then transportation and roads and then to come back in 3 weeks and all of those kinds of things. Consistent messaging from our governing bodies so that the average person can have a better understanding of what's going on, that it's dynamic, that it's not, that today's information is today's information, but it may not necessarily be the same information next month. And that's not necessarily a bad thing in the sense of it doesn't negate the whole process. And then certainly some standardization around social distancing, practicing, mask wearing, hand washing, all of those things, and dealing with super spreader potential events in a way that makes sense, not just in this area we'll allow it, and then over here, we don't do those things over there. Having some more standardized guidance, I think, would be helpful for the masses to kind of understand and ingest.
And then I'm going to ask the same question of our two more sage, or at least older moderators, Dr. Neighbor Stevens and Dr. Walks.
I guess I'll go. I know the first thing that I would hope our policymakers would do would gather around them people who are really expert in messaging. Because I think we have made a mess of messaging in this country, and I'm sure the misinformation and the poor messaging that has occurred in this country is not restricted to this country, it's heard around the world. So we need to get our act together around that. And I think we have people in this country that can do a much better job than has currently been done. Secondly, I think we need to understand in the policies that we put forward and the execution strategies that we develop, that we fully understand the cultural dynamics at play so that they will be more eagerly embraced by the communities that we are trying to address. And then third, I really want to go back to something you said, Dr. Hines, about understanding change. For whatever reason, we are so rigid in our thinking. So we need to do some education around what science is and what is the nature of the beast that we are engaged in fighting, so that we understand globally that with time, new information will mean new strategies. So don't get so put off by the fact that what was totally appropriate perhaps at the beginning of the pandemic may not be appropriate now, and vice versa. Things that were very appropriate then are still very appropriate now.
Dr. Walks.
So, okay, having served in a role as a state public health official, let me say this. One of the most successful public health things that we did in Washington, D.C. had a penalty attached to it. We did something called No Shots, No School. And over the course of several months, we went from less than 50% kids vaccinated to over 99% kids vaccinated, because you needed to show that you had been vaccinated in order to come to school. This whole thing about personal choice and all of that, it makes me crazy. It makes me nuts, because people are dying while we're trying to have personal choice. In America, we don't have personal choice all the time. So if you gave me America and the world, Dr. Maxey, be very afraid, because I would put penalties in place, people would get vaccinated, and we would be done with this. I don't understand why we are willing to tell people this is mandatory because it'll protect your health on Tuesday, but we are not willing to say to people this is mandatory because it'll protect your health on Wednesday. It makes no sense to me. It's inconsistent. And maybe that's the most inconsistent public health message that we have, is that we are inconsistent about making public health something that has to happen. So don't put me in charge of anything, Dr. Maxey, because it'd be a whole different thing. Can I yield the rest of my time to my dear friend, Dr. Jordan, who has been waving his hand, and I'm afraid he'll come to my house and punch me in the face. So can we please unmute Dr. Jordan?
The famous mentor of mine, Dr. Wilbur Jordan, you're speaking about?
Absolutely.
Well, Dr. Wilbur Jordan, you are privileged. Please unmute yourself.
I have unmuted myself. And you stop telling people I'm your mentor. They're going to think I'm older than you. I think we forget. I remember when we had polio vaccination. We were in the South. We didn't have a chance to have any input. The white folks told us what days we would be vaccinated, where we would go to be vaccinated, and that's what we did, period. So it's an interesting evolution that has happened. I'm glad you made the comment about Africa. Africa is a continent. It's the second largest continent in the world. And like with AIDS, most of the American companies gave the formulas to India, Egypt, and South Africa to make drugs for Africa. But for us, on the one hand, to think that Africa has beat everybody and has all this, it's nearly an oxymoron in terms of that, period. I think we need to make sure that we, as Black people, know what the hell is going on in Africa as well. I think the one thing that I think we still need to emphasize more is too many Black people in this country don't have a primary care doctor.
Mm-hmm.
Now, I went over all of our OASIS patients, and I stopped at 5,000. I found 4 Blacks who were referred to the clinic. I found more Hispanics. I even found more whites who were referred by their primary care doctors. We provide the primary care service for our Black patients. And I think that's something we need to deal with, not here, but at a different level, is as a people, we don't seek out primary care routinely. We go to either the emergency room, BD clinic, or maybe an outpatient center, but we don't go to doctors. And I think that's dangerous, and we're going to end up paying for it a lot. Thank you.
Thank you so much. And we're close to the time where we end our program, but I want to just take a license a moment. And this is to Dr. Despani, and then I have a gentleman on the phone from Baton Rouge. Given that there are some concerns about the biological, pharmacological treatment of these various organisms, including viruses, what is the future of non-biological, non-pharmacological treatment, such as ultraviolet light, mechanical treatment? And recently you and I reviewed a device that Mr. Dorsey had that kills viruses in the air. Is there a role for those types of things in the future, as in addition to what we're doing with vaccines and biologicals, Dr. Despani?
Absolutely. Yeah. The whole thing is, and taking that combinatorial approach, one of the best approaches actually is to leverage some type of physical or chemical element that actually cannot be changed by virtue of the fact that you can't change, the fact that ultraviolet radiation is going to destroy a virus, right? It would take a long time for SARS coronavirus 2 to ever evolve any type of mutation, which is to not say that won't happen. I do know of certain species that can evolve, like Radiococcus urens, I believe, but it takes a long time. And again, if we're taking a combinatorial approach, just think of it this way, right? The virus right now is having fun because it can basically only worry about either an uninfected person or a person who might have a vaccine. So it's like, oh, this is easy. Now, if you're like, I guess, engaging in like a gang fight with it where you're like hitting it from every angle, it's like, okay, this is not easy. This is not fun. I will be endemic. Now, keep in mind that the virus, like, we can't put this genie back in the bottle anymore. So the best we can hope for is that it becomes endemic, another thing, the denizen of our common cold season, but that's how it is. I mean, this is not the first coronavirus that infects humans. 4 coronaviruses that infect humans are actually, infect us all the time, like OC43 and 229E. So that's the hope for the virus moving forward, but we have to try everything.
Well, thank you very much. Mr. Dorsey, if you put your information in the chat, we'd appreciate that. I was hoping we could look at that video for a moment. I'd like to have a quick round robin of our moderators, unless there are any other questions or comments in the chat. I want to invite our closing team. Is Pastor Pointer on, Dr. Walks?
I do not see Pastor Pointer on now. No.
Okay. All right. Dr. Hines, do you have a final word?
I just thought that the combination of talks for today was really great because on the one hand, we've ended here with, here's what's coming, but don't be too freaked out about it, even though it might be a problem. But and where we started was about the impact of COVID on our mental health, even outside of just, whether or not you actually get infected with COVID, right? And I think it's just a real good point of perspective about fear and managing and acknowledging, any feelings that you're having, depression, isolation, anxiety, especially as we're coming off Thanksgiving and the potential spaces where we could have gathered with our loved ones that we may not have seen for a while. It's just an interesting combination of topics, right? Because on the one hand, it is the acknowledgement that we need to be careful how we gather, but also acknowledging that we do need to have some personal contacts and keep in touch with our friends and family and loved ones, even in a way that makes sense as we continue to move forward. So it was just a really good, timely combination of talks.
Dr. Walks?
Thank you, Dr. Maxey. Thank you for that really nice summary, Dr. Hines. I think I would certainly agree with everything that you just said. One of the comments I want to make is that this is such, it's always very exciting for me when we do what we've done today, which is get a combination of perspectives that relate together. Dr. Despani always brings us so much good, clear, well-explained science. And I think we see how folks respond with all the questions that pop up in the chat. And Dr. Lawson, I remember we had a comment several meetings ago about, I think Dr. Maxey and I had made a joke about mental health or about psychiatry, and we got a very appropriate rebuke, because there is a lot of science in mental health and a lot of science in psychiatry. And Dr. Lawson, being one of our chief researchers in that area for many, many years, is able to demonstrate that very clearly. And I thought that it was wonderful to have these 2 scientific presentations today. So thank you both.
Thank you. Before I ask Dr. Neighbor Stevens, Dr. Walks, I'm going to be coming to the DC area in December. I'd like to know if you can find a place where several of us can have lunch that are on your committees and my committees, that's outside but heated. I'd appreciate that sometime between December 23rd and January 3rd. It's just got to be heated and outside.
I'm going to be out of town, Dr. Maxey. I will not be available, Dr. Maxey. I'm leaving town. No, no, I'll make that happen, sir. You got it. I'll make it happen.
That's the neighbor Stephen.
Well, I always like to give us the down-home practical advice to take with us for the week. And we've always emphasized the mask and safe distancing and advocated, and the hand washing and advocated for the vaccinations. However, what we have not, I can't recall us ever really putting any emphasis on has been the role that rapid testing can play. And the reason I'm bringing this up is as we have just passed one time of family gathering and we have another one fast approaching. Don't forget, now they're not 100%, they are not the gold standard, but some of the rapid tests, and we probably need to spend a little more time on this in a future meeting, but some of the rapid tests can help you make some give you an additional layer of protection as you try to balance living in a state of an epidemic as well as continuing normal family relations. So I just wanted to bring that out today. They have reduced the price of many of them. The government is subsidizing the cost of them at Walmart, and I can't remember this, but I'm sure you can find Google and you can find that out. And just remember that if you have concerns about yourself or someone around you, that you can use the rapid test as another way to try to find your way in this maze.
Thank you. Dr. Lawson and Dr. Despani, final words.
I go. I have two things to say. First, parlaying off of what Dr. Walks had mentioned, the reality is that we can't live in a place where there are rights without responsibility. So we're now being called on to engage in being responsible with public health. And then secondly, parlaying off of some of the data that Dr. Lawson had shown at the beginning concerning the 1918 Spanish flu, that actually killed 650,000 Americans. We're now going through a pandemic that has led to the deaths of 770,000 people. And it was joked that this was no worse than a common cold, yet it's killed more than an epochal pandemic that happened almost over 100 years ago. So yeah, the reality is that we should probably rely upon the biblical dictum that, see, I have set before you life and I have set before you death. Choose life. That's all.
And I just want to note that the bottom line is that no matter how much technology we have, ultimately it resorts to the extent to which our behavior wants to commit our resources to be able to solve these problems. We've gone a long way if we had learned from the past, and we need to do what we can to create institutions to be able to prepare for the future.
Well, thank you, everybody, for joining us today. Thanks for the vigorous discussion. Thanks to our presenters, our moderators, and all who participated, and my mentor, who is really not only Dr. Williams, but Dr. Jordan, and they are older than me, both of them. Have a good day, everybody, and Lord bless everybody. Amen.
Amen. Amen.